Okay, so I did my presentation on measles and mumps. So, first one we're going to talk about is measles, aka it's also called rubeola. Okay, so etiology. So, measles is a highly contagious childhood infection caused by a virus, and it gets replicated within the nose and the throat of the infected individual. And it's so contagious that if one person has it, up to 90% of people close to them who are not immune will also be infected. It used to be common, but now it's almost always prevented with a vaccine. It can be transmitted through sneezing, coughing, or talking. The infected droplets that are in the air can be inhaled by others, and those infected droplets can be active within the airspace for up to 2 hours. Also, individuals can be infected if there are infected droplets on surfaces. So, those are also very active and contagious up to several hours. So, if an individual puts their hand on the infected surface and puts their fingers in their mouth or in their nose or in their eyes, that's another way where they can contract the virus. An interesting fact is measles is a disease of humans, so measles can't be spread or um, by contracted by any other species. So when we're talking about patient signs and symptoms of measles, so symptoms they can occur within 7 to 14 days of exposure. They get a high fever that can spike up to 104 degrees. There's a cough, runny nose, red watery eyes, white spots called Colpic spots in the mouth, and then a rash will break out, and sometimes ear infections can occur as well. So, a little bit about the timeline of the symptoms. So, 2 or 3 days after symptoms begin, tiny white spots, those Colpic spots, start to appear within inside the mouth. And then 3 to 5 days after symptoms begin, a rash will break out. So that rash begins as flat red spots that appear on the face and at the hairline and spread down the neck, the trunk, the arms, the legs, and the feet. And then small raised bumps start to appear on top of those flat spots. And then eventually those spots start to join together and then they spread all over the head and the rest of the body. Something else to note, the infection could be spread to others between 4 days before symptoms appear and up to 4 days after the rash appears. And then some complications of measles. So 1 out of 4 cases or patients are hospitalized. 1 out of 20 patients develop pneumonia. 2 out of every 1,000 die from respiratory or neurologic complications. And then 1 out of 1,000 develop encephalitis, which if the patient does develop encephalitis, that's when more complications occur. So vision impairment and blindness can occur and hearing impairment. So there's an increased risk of otosclerosis with having measles. The type of hearing impairment would be bilateral profound deafness, and there's also bilateral vestibulopathy, so bilateral weakness. When it comes to ear infections, I should just go back to that. 1 out of every 10 cases will develop an ear infection. All right. So I just wanted to include some pictures. So on your left side, that is the presentation of the rash outbreak throughout the body. And then on the right side, this is a presentation of the Colpic spots inside a patient's mouth. And with the body outbreak of the rash, that develops within 3 to 5 days after the initial symptoms begin. Okay, so pathogenesis. So measles is caused by a single-stranded enveloped RNA virus with one serotype. It is a member of the genus Morbillivirus in the Paramyxoviridae family. And so this is just one member of that family. And through research, I found out there's 49 species placed in that family. And again, I know I already talked about this, but humans are the only natural hosts. You can't contract it from any animals. Okay, so epidemiology. So it can be very fatal for small children. It kills more than 100,000 people a year, most under the age of 5. Has not been widespread in the US for more than a decade, except for recently. So the CDC did report um, from January 1st of this year to May 24th of 2019, there has been 940 cases that have been confirmed in 26 states. And the increase has been said due to unvaccinated preschool age children and vaccine non responders. So, vaccine non responders are individuals who did get the MMR vaccine, but due to a failure of the immune response to that vaccine, it just never takes. So, they are called vaccine non responders. Um, so 2019, this has been the greatest number of cases reported in the US since 1994, and measles was declared eliminated in 2000. So unfortunately, no longer considered eliminated. And the fatality rate currently is 10%. Okay, so I just wanted to put this little graph on here from the CDC. And this is just a number of measles cases reported by the year. So it's from the left, you have 2010, and then going across, we are ending at 2019. So you can see there is a substantial increase in the number of cases reported. Okay, so some risk factors. So measles is serious for all age groups. However, risk factors include those who are unvaccinated, those who travel internationally and are unvaccinated, or the vaccine non responders. If they have vitamin A deficiency, small children who are unable to get vaccinated, so younger than 5. So when it comes to vaccination for utilizing the MMR vaccine, small children get their first dose of the vaccine between the age of 12 and 15 months, and then they don't get their second dose until the age of 4, between the age of 4 and 6. Pregnant women are also have a higher risk, and then people with compromised immune systems. So if I go back a little bit, so traveling internationally, so there's a lot of developing countries where measles is very common because they do not administer the MMR vaccine. Japan is one of those countries. So when individuals travel to those places and then come back, that is where we are seeing where the outbreaks are starting to occur is based on these situations. Let's see. The vitamin A deficiency, not having enough vitamin A in their diet, will cause the individual to have more severe symptoms and complications with measles. So it's not technically a risk factor of contracting measles, but it is a risk factor for having more complications and worse symptoms. And then when it comes to pregnant women, I just thought this was something to note as well. If they do not have the MMR vaccine and they do contract measles, they are at a high risk of giving birth prematurely, or that baby has a very low birth weight when born. So some clinical and differential diagnosis. So how measles is diagnosed. So lab confirmation is essential. It's pretty much the first, the most important way of confirming and diagnosing measles. So What they're looking for is the detection of measles-specific IgM antibody in serum and measles RNA by real-time polymerase chain reaction in a respiratory specimen. So that's the most common thing that they're looking for. A throat swab could also be done as well, and the virus can also be detected in urine samples as well. So we are talking about differential diagnosis. So some pathologies that look similar in presentation, some of the presentations of measles include labyrinthitis, bacterial meningitis, autoimmune disorders of the inner ear, ototoxicity, and Ramsay-Hunt. So again, that is why lab confirmation is essential, just to differentiate the presentations from the rest of the pathologies. So when discussing hearing loss, so hearing loss is a result of a complication with measles. So that what that means is hearing loss is not a guarantee when contracting measles. It is just if for whatever reason the measles gets out of hand and there is complications and encephalitis occurs, hearing loss is more likely to occur. So if hearing loss does occur, it's because the body's immune response to the virus damages structures within the ear. So there's cochlear disruption, so organ of chordae atrophy, atrophy of the stria vascularis, abnormal fibrous tissue developed at the base of the cochlea, which is suggestive of inflammatory reaction. Otosclerosis is also said to occur in some cases. So it's hypothesized that otosclerosis occurs due to histology reports that suggest that measles infections contributes to otosclerosis. And it's said due to inflammatory changes that occur in the ear with the disease, there is a higher risk of developing otosclerosis. And what was noted was since the MMR vaccine, otosclerosis rates have decreased substantially. So there is vestibular disruption as well. So in temporal bone studies, it shows that the infection travels from the subarachnoid space to the inner ear, with the eighth nerve and with the eighth nerve also being infected. Okay, so audiometry. So like I said, if hearing loss does occur, these are some things we would be looking at as audiologists. So post-measles infection, so we would be seeing a bilateral profound sensorineural hearing loss, usually with no recovery, or if otosclerosis has occurred, a mixed hearing loss. So speech testing, PTA and SRT would be in good agreement. Word rec would be dependent on the severity of the loss. OAEs, there's no literature on this, but assuming based on the degree of the loss, they would be completely absent. Admittance, depending on if they have otitis media, you would see type B TIMPs and absent reflexes. And without otitis media, type A TIMPs and the reflexes would be also dependent on the degree of loss, but likely absent. And the reason behind otitis media in some of the cases is just due to the immune system being compromised. Okay, so electrophysiology. So ECOG results dependent on the severity, but most likely would have an absent response. It's not diagnostically useful. ABR, this testing could be performed to determine hearing level for children who are too sick or due to neurologic complications from the virus, so like encephalitis. With the severity of the loss, what you would see would be decreased morphology, and wave 1 could potentially be absent. So when we are looking at vestibular testing, site of lesion, bilateral peripheral weakness, so ocular motor testing, you would see it would be normal because most ocular motor testing would be looking at central lesions. Positionals would be normal. Normally, what we're looking for is nystagmus for these tests, and normally the nystagmus would be towards the more neurally active side, but because there is a bilateral loss, there's no neurally active side. So you wouldn't be seeing nystagmus beat to either side. Head shake, again, normal because there's no neurally active side. Hyperventilation, again, normal. When it comes to V-hit, you would see positive head thrusts bilaterally, so on both sides, and you'd see either covert or overt saccades. When we're looking at calorics, we would see bilateral weakness. Dix Hall pike would be normal. Rotary chair, we would see low gain, which is indicative of bilateral weakness. Symmetry would be normal, but you would see low spectral purity, and this is consistent with a complete bilateral loss. Step test, you would see short time constant. Symmetry would be normal. And something to think about as well with individuals who do have bilateral weakness, they may be complaining of oscillopsia and imbalance. So that's always something to ask during a case history. So medical management. So post-measles exposure, isolation up to 4 days after rash would be important. You are able to get a post-exposure vaccine. So these could be for individuals who are who have not received the vaccine before, so like infants. This post-exposure vaccine can be given within 72 hours of exposure to the measles virus, and it can provide some protection against the disease. If measles still does develop, though, usually the symptoms are a lot milder and occur for a shorter duration. Immune serum globin. So for those who are pregnant, infants, or people who have compromised immune system and are exposed to the virus, they can receive an injection of antibodies called immune serum globulin. And when given within 6 days of exposure, these antibodies can prevent measles or, again, make symptoms less severe. And then blood tests as well, post-measles exposure, just to confirm the presence of measles. So more for medical management. So if measles is contracted, to help with the symptoms, fever reducers could help. Antibiotics for any secondary infection. So like I was saying earlier, otitis media can occur due to the compromised immune system. Vitamin A, because like I said as well before, if you are vitamin A deficient, it causes for more severe symptoms. So just making sure that there's no deficiency in vitamin A could potentially help. A lot of rest, hydration, respiratory relief, chest x-ray to monitor for pneumonia is important, and then lumbar puncture as well if encephalopathy is suspected. So for audiologic treatment, cochlear implant candidacy for individuals with bilateral profound sensorineural hearing loss, PE tubes potentially if need be for any otitis media cases, stapendectomy if otosclerosis does occur could be a potential treatment, hearing aid trial, ALDs to increase SNR, vestibular rehab, and use of compensatory strategies. Because the vestibular system is compromised, utilizing visual and somatosensory input will be very important for these individuals. So some treatment success rate. So the MMR vaccine has been shown to be safe and effective. So 2 doses of the MMR vaccine is said to be 97% effective. 1 dose is 93% effective. And there wasn't very much literature, there wasn't any literature found on amplification success rate. And I think this is due to um, measles was considered eliminated in 2000, and just recently there has been shown to be more outbreaks. So I think, and hearing loss is just a complication of measles. So I think just because it hasn't been such a problem recently, there isn't much research showing um, the treatment of amplification. Okay, so now talking about mumps. So, etiology. So, same as measles, it's a viral infection, but this time it primarily affects the salivary glands located near the ears. Spreads from person to person through direct contact with infected saliva or respiratory droplets from the mouth, nose, or the throat. And it can be spread before the salivary glands begin to swell and up to 5 days after the swelling begins. And then I found this quote um, that kind of shows how contagious mumps can be as well. So a single case can result up to 12 secondary cases in a susceptible population. Okay, so when we are talking about patient signs and symptoms, so symptoms include um, puffy cheeks, tender, swollen jaw, fever, headaches, muscle aches, tiredness, loss of appetite, and then 45% of patients complain of vertigo. So a little bit of the timeline on these symptoms. So symptoms appear between 16 and 18 days after infection, and it can range between 12 to 25 days. So 3 to 5 days after exposure, parotitis begins. So that's swelling of the parotid glands. Other areas that can also start to swell would include eyes, the pancreas, the testicles, joints, the central nervous system, kidneys, and swelling can last for up to about 10 days. Earaches on the affected side is very common. So normally it is seen that the swelling is occurring on the affected side. So, and hearing loss can occur due to neuritis. Um, and there's signs of both auditory and vestibular nerve involvement. So, some complications, I already mentioned some of these. Complications include inflammation of the testicles, ovaries, and or breast tissue, pancreas, brain, meningitis. Unilateral sensorineural hearing loss is another complication. So 1 in every 20,000 cases. So it's not as common. Again, it's just a complication if mumps gets out of hand and isn't treated. Fever, confusion and disorientation, and abdominal pain. So I did just want to include just a picture so you can see all the swelling on this child. Okay, so pathogenesis. So mumps is a viral illness caused by the perimyxovirus, and it's a member of the rubeola virus family. The virus causes the parotid glands of the neck to swell. The virus can be responsible for cochlear disruption, or the cochlear disruption is due to the body's immune response. So there's damage that can occur to the stria vascularis, the tectoral membrane, and organ of Corti. And then the virus also has been shown to be existed in the perilymph fluid. And that's when the patient suffers from what's called mumps deafness. And then there has been temporal bone evidence that states sometimes the site of lesion can be the inner ear and the 8th cranial nerve. So epidemiology, so prior to the MMR vaccine, it was a very common childhood illness. Still an epidemic in some countries due to them not administering the MMR vaccine. So, like I was saying earlier, Japan is one of those countries. It's considered to be rare in the United States. Mumps deafness is said to occur in every 5.1 per 1 million cases. So, again, very uncommon, and hearing loss is just due to a complication of um, mumps. So, like I did with measles, as of April 26, 2019, there are said to have been 736 cases reported in 2019. Um, and then approximately 1 out of 20,000 are affected. Um, of affected persons with mumps experience unilateral sensorineural hearing loss. And then 5 out of every 1,000 infected persons develop some form of encephalitis. So again, here is another graph that I took from the CDC's website looking at mumps reported cases from 2000 to 2019. And for 2019, this is just some preliminary data as of right now, so 716 cases as of April of 2019. Okay, so when we are looking at risk factors, so the population greatest at risk is adolescents and adults. So pretty much anybody. um, Symptoms are most severe in adolescents, but can be in adults as well. So unvaccinated individuals who are exposed to the virus are at risk. Those who travel overseas while being unvaccinated, and just anybody who is close to an outbreak are also considered to be at risk. So it has been stated that 99% of mumps cases has decreased in the US. However, outbreaks are still occurring. And then during these outbreaks, individuals who have had one or both doses of the vaccine have also been shown to get mumps as well. And it's unsure why these vaccinated people are still getting mumps. And the theory is that the immune system just did not respond well to the vaccine the first time. So, kind of like the vaccine non responders, it's not really sure. That's just a theory on why vaccinated people are still getting mumps. Let's see. So, same thing like I was talking about for measles, the vaccine is administered. So, the first dose is between 12 to 15 months, and then the second dose is administered between 4 to 6 years of age. Let's see. Okay, so when we're looking at clinical and differential diagnosis, so diagnosing mumps, so history of exposure. So again, just like measles, hearing loss is a result of a complication with mumps. It is not a guarantee. So if hearing loss does occur, it is called mumps deafness. So what we would be seeing when we're looking at audiometry, so the hearing loss, sudden onset of unilateral profound sensorineural hearing loss, can be reversible, but sometimes it is severe and permanent. And it's noted that the side of the parotid gland swelling is not always correlated with the side suffering with deafness, but it has been shown that that can occur. So speech testing, PTA, and SRT are in good agreement. Word rec is dependent on degree of loss. OAE is consistent with degree of loss, normally absent unilaterally. Emittance type A, TIMPs, and absent reflexes on affected ear side. AEP, so ECOG, dependent on the severity of loss, typically absent, but again, just like measles, not diagnostically useful. ABR can be used to help confirm severity of loss. in pediatric patients who can't confirm behaviorally. With cochlear losses, you will see poor morphology at high intensities and sometimes may see an absent wave one. So with vestibular testing, ocular motor testing would be normal because you normally, again, those are looking at central um, pathologies, but gaze is the one testing that can also look for peripheral lesions as well. So if it's peripheral, you'll see nystagmus in the center gaze, it has fixed direction, it follows Alexander's law, and nystagmus is enhanced when fixation is removed. So with positionals, you'll see nystagmus beat horizontally toward the neurally active side, and then head shake. There is horizontal post head shake nystagmus that will be toward the more neurally active side as well. So hyperventilation, nystagmus beats toward the more neurally active side. With calorics, you'll see the unilateral weakness, so if it's more than 25%, and there's just a calculation down there for you. With VEMPs, C-VEMPs, you'll see it absent on the affected side. You'll see asymmetry ratio, so more than 40%. And the weaker ear is the pathological ear, and latency can be affected as well. With V-hit, you would see a positive head thrust toward the pathologic side, and you'll see overt and covert saccades noted toward pathological side. So for the Shaw testing, gain would be normal, symmetry would be abnormal. Step test, you would see a short time constant, which is indicative of a peripheral lesion. Asymmetry as well, so more than 30% for gain and time constant. Visual suppression and enhancement would be normal. SVB, the line would point towards the site of lesion. SVH, if the line is abnormally up, you will see it'll be the right ear is the pathological ear, and then if it's the abnormal line is down, it'll be the left ear. And then unilateral centrifugation is normal, and fistula testing is normal. So medical management. So most recover from uncomplicated cases within a few weeks. It's no longer contagious and safe to return to work and school approximately 5 days after the appearance of signs and symptoms. But you should get clearance from a medical doctor first before returning. A lot of rest is recommended, definitely isolating self to prevent any spread to others. And MMR vaccine is also important. And what they use is a live version, attenuated version of the virus. So I know I've said this before, but again, first dose is administered between 12 to 15 months of age. Second dose is 4 to 6 years of age. And there was a study that did recommend doing a third dose in the teens or early 20s just to prevent mumps, because again, there are some individuals where their immune system just does not take the MMR vaccine the first time, so just to make sure that the immune system is responding, then some recommend that third dose. And then the vaccines are said to be safe and effective. So persons with 2 doses of the MMR vaccine has shown an 88% reduction in risk for mumps. And then individuals with 1 dose show a reduction of 78%. So again, for medical management, just to ease the pain, there's not really a medication for you to be able to take to get rid of mumps. So to ease the pain, an over-the-counter pain reliever or a non-steroid anti-inflammatory, cold compress to help with the swelling, avoid foods that require a lot of chewing, and then just a lot of fluids. A study that I did look at developed this type of um, prevention control tool to be utilized within their clinic. And this tool is called the Identify, Isolate, Inform tool, the 3I. And it was originally developed for the Ebola virus in 2014, but now it is utilized for many contagious viruses, including measles and mumps. So, step one would be to identify patients with a risk factor um, coupled with symptoms. Step two, isolate those individuals. Um, they need to be isolated immediately. And then step three, inform both the public health and hospital prevention authorities. So this was just a little flyer from that study on the different steps that are needed to be taken if an individual comes in and a confirmation of measles or mumps have been confirmed. So audiologic treatment. So BAHA could be utilized, across could be utilized, ALD for better signal to noise ratio, especially for the individuals with unilateral hearing loss. CI in the rare case of bilateral deafness, or single-sided implantation if private pay, or if you can find a place that will do it. If meningitis occurs, obviously CI candidacy. And then for the vestibular problems, vestibular rehab and just a lot of exercise. So treatment success, I already discussed this. So the MMR vaccine has been shown to be safe and effective. 2 doses of the MMR vaccine is said to be 88% effective, and 1 dose is 78% effective. And again, same thing as measles, no literature has been found on the amplification success rate. So I just wanted to do just a little compare and contrast between the two, since they do have pretty similar presentations. So measles and mumps, for similarities, measles and mumps are both a reaction to a virus. They both utilize the MMR vaccine. The age of administration is the same. They're both highly contagious. The transmission is pretty much the same. Hearing loss is not guaranteed, but a complication of the virus. Isolation is very important for both diseases. The risk factors are the same, so those who are unvaccinated, compromised immune system, small children, pregnant women who are unvaccinated, and if you're traveling and unvaccinated. And then blood test is what is utilized to confirm the virus. So differences between mumps and measles. So hearing loss. For mumps, it is unilateral. In the majority of cases, it's unilateral profound sensorineural hearing loss. For measles, it's bilateral profound sensorineural hearing loss or a mixed hearing loss if otosclerosis has occurred. Vestibular effects, so mumps, normally unilateral weakness, measles, bilateral weakness. Symptom differences, for mumps, you'll see that swelling of the parotid glands or of different areas in the body. And then for measles, there's an outbreak of the rash. And then complications of the virus, so mumps, swelling is complication, infertility. And then for measles, blindness and encephalitis. Okay, so case study. So the case study includes a 6-year-old female. She came in to a hospital. Her symptoms included fever and swelling of the left parotid gland and both submandibular glands. She visited a private hospital where sialodinitis, secondary to mumps infection, was diagnosed. The patient had type A TIMPs, noted bilaterally. So 4 days after the onset of parotid swelling, the patient noticed a decrease in her hearing in the left ear, and she returned to the hospital. So this is what her first audiogram looked like. So moderate sensorineural hearing loss in the left ear, and the mumps virus was diagnosed. So this is the second audiogram, so 5 days after onset of the parotid swelling. So as you can see, there was a decrease in that left ear, so a severe sensorineural hearing loss was found. So there was treatment that was applied, so a drip infusion of dexamethasone, and I'm going to try and say that, was given to the patient, but it did show that her hearing just got worse after that. And then the ELISA for immunoglobulin M and G against mumps were positive. So this was suggestive of mumps being the primary infection for this individual. So 7 days after the onset of the swelling, the patient's symptoms included severe vertigo, nausea, and vomiting. 14 days after the onset of the swelling, a neurologic exam was performed. They found spontaneous right beating nystagmus, and it was noted that the eighth nerve was the only cranial nerve abnormality that was found during that exam. In calorics, there was severe left unilateral weakness. For Mumps, it showed left ear response was absent and the right ear response was normal. And then the Romberg sign was positive. So the Romberg sign, just to review, is a balance test where the patient's asked to stand with their eyes closed, and it's considered a positive test if there was an increased loss of balance. So here are just the test recordings found in the study. So spontaneous nystagmus recording on the left side, and then the caloric results on the right. So Mumps recording was here. So this was indicative of, this was CVEMP, so indicative of sacral dysfunction on the left side. And then another test that I wasn't very familiar with is called the CBST. So the method behind this is you are stimulating electrodes placed on the mastoids bilaterally, and a cathode is placed on the forehead. And then beginning of each stimulation, positive currents causes the body to sway from side to side sway to the side of the stimulation. And so stimuli is delivered to each ear, and movements to the left and the right recorded using a personal computer. So just a little recap more about the CBST. So galvanic current is applied to the transmastoid, and it causes the body to sway in healthy subjects. But there's a no response in patients with retrolabyrinthine disorders, such as vestibular neuritis, acoustic neuroma, or any pontine lesions. So the galvanic current stimulates the vestibular nerve directly. So GBST results. So there was a normal body sway when stimulation was occurring to the right side, but there was no sway to the left side, which is indicative of issues to the left nerve. So some conclusions after the exams or after the assessments and other testing was done. So protein and sugar levels in the cerebral spinal fluid was shown to be normal. MRI findings were normal. And so after this, it was concluded retrolabyrinthine and inner ear dysfunction. um, has occurred secondary to the mumps infection. And then it was noted that the GBST is helpful for evaluating labyrinthine dysfunction because it stimulates the nerve only. Okay, so 1 week later, so this is 18 days after the onset of the parotid swelling, the patient recovered from the vertigo and nausea. However, the hearing loss progressed and was complete deafness. And then an ABR was done and it was absent. So there was a 6-month follow-up appointment, and what they found was there was no spontaneous nystagmus. The Romberg sign was negative, so there was no imbalance. Um, there was still caloric unilateral weakness on the left side. The VEMPs was absent on the left side. However, there was the GBST showed normal responses for both sides. So what was concluded after the 6-month appointment was that the retrolabyrinthine vestibular function was restored. However, the hearing loss was persistent. So how this case would be different if the virus was measles. So their symptoms, there would have been an outbreak of rash and the Colpic spots if this was measles. The hearing loss would have been bilateral profound sensorineural hearing loss or mixed with otosclerosis. In vestibular system, you would have seen bilateral weakness. However, treatment's the same, isolation. So something curious when I was doing my research about measles and mumps, there is the phenomenon about potentially MMR vaccines causing hearing loss. I didn't really go that much in depth in researching it, but from one study, these are just a couple quotes within the study. So sensory neural hearing loss associated with vaccination ranges in severity, can be bilateral or unilateral, and has been reported in both pediatric and adult populations. The incidence, though, is 1 case per 6 to 8 million vaccine doses, or vaccine doses. Patient symptoms such as fever, rash, headache, and ataxia has been reported after vaccination and prior to the onset of the hearing loss. And it's said to be a result of vaccination-induced encephalitis. A review by the Institute of the Medicine concluded that while hearing loss due to the measles vaccine strain was possible, there is insufficient evidence to make conclusions regarding a causal relationship between the vaccine and hearing loss. So I just thought that was interesting. So these are my references if you want any more information. And thank you.